guys. In this lesson, we are going to be talking about the basics of congenital heart defects. There's a lot to talk about for this topic, and I think it can be overwhelming sometimes, but we are going to break it down and make it really easy for you. Okay, so I think this is pretty obvious, but congenital heart defects are just abnormalities in the heart's structure. And these are going to be present from birth, so that just means that they're not acquired like the kind of damage that you might get from something like rheumatic fever. And a lot of times these defects are associated with other syndromes and other chromosomal abnormalities. So patients who have Down syndrome and Turner syndrome, they are actually the most common syndromes that also have heart defects. So we're really on alert for that. And we do really thorough screening of these babies in utero to check for these things. And there are some other risk factors as well that can actually contribute to the development of congenital heart defects in utero. And these are really important to know for our patient education and our screening. So if there's a family history of heart defects, kids are more likely to have them. And then if there's a maternal diagnosis of diabetes or lupus, or if the mom used any kind of drugs or alcohol during her pregnancy, or if she was exposed to rubella at all, or if she was taking any kind of teratogenic medications like phenytoin. So before we move on to talk about some of the specifics of heart defects in kids, I just really want to quickly go over some things that are really important for understanding this topic. So the first thing that you have to know is that pressure on the left side of the heart is greater than the right side of the heart. This is because the left side of the heart is having to push against all of the systemic pressure, where the right side of the heart is just pushing against the pulmonary system. So this means whenever there's a hole in the heart, in the septum probably, the blood is going to naturally just shunt or move from left to right. So just keep that in mind as we go through these different defects. And the next thing you need to know is that in utero, babies actually have 2 extra holes in their heart. And they are the foramen ovale, which is here, and then also the ductus arteriosus. And these 2 things are really important for fetal circulation. And we have a whole lesson on that for you that you can check out in the OB course. But when a baby is born, these usually close due to pressure changes. So if you need to know more about that, definitely go look at those lessons. But for our purposes, what you need to know is that when and if these remain open, what they do is they allow blood that's not been oxygenated to mix with oxygenated blood. Now, for the most part, this isn't a good thing for oxygenation in the body. But with some of our heart defects, it's actually really important that these are open so that blood can mix and more oxygen can get to the system. And we'll talk about that a lot more in other lessons, but I just want you to keep that in mind as we get started. I mentioned that there's a lot of information to digest with this topic, and one way that we can help to sort of manage this information is to classify the different heart defects. So back in the day, we just used to classify things as being acyanotic or cyanotic. And we don't really do this anymore because it oversimplifies things, and really any heart defect can cause cyanosis if it goes untreated for long enough. So this is kind of old school, and we don't really do it anymore, although we will kind of mention a few heart defects that are more likely to be cyanotic than others. The more helpful way to classify or to think about heart defects is to think about hemodynamics. And what I mean by hemodynamics is just that the way the blood is moving. So we're going to talk about each of these heart defects and classify them according to how they impact the way that blood is moving through the heart. And there are 4 different categories that we're going to look at. So heart defects can actually cause an increase in pulmonary blood flow. It can cause a decrease in pulmonary blood flow. It can obstruct the flow of blood, or they can actually depend on the mixing of blood. So this means that the heart defect needs the blood to be mixing. And so we're going to take a look at all of these different categories and the different defects that go along with them in different lessons. But let's just take a quick look at what they're called. So there are a lot of words on this slide, but we're going to break those down in all of the other lessons that I mentioned. So let's just run through this really quickly. Atrial septal defect, ventricular septal defects, atrioventricular canal defect, and patent ductus arteriosus. These 4 cardiac defects all cause increased pulmonary blood flow. And then you have tetralogy of Fallot, tricuspid atresia. Both of those cause decreased pulmonary blood flow. And then the 3rd category we have is the obstruction, and those heart defects are coarctation of the aorta, pulmonic stenosis, and aortic stenosis. And then for our mixed defects, we're looking at transposition of the great arteries, truncus arteriosus, and hypoplastic left heart heart. So like I said, we're going to go through all of those, and they'll make a lot more sense to you when you look at those different lessons. Okay, so for your assessment of a child who has a congenital heart defect, you already know how to do a cardiac assessment. So I'm just going to highlight for you a couple of different things to think about when you're assessing kids. So for the first thing here, you're definitely going to want to listen to those heart sounds, and you're going to want to check that heart rate. And when you do this, just keep in mind that for kids, bradycardia isn't less than 60 beats per minute like it is with an adult. For an infant, bradycardia could actually be 90 to 100 beats per minute. So you've got to make that mental adjustment when you're assessing heart rate in little bitty kids. Bradycardia is going to be age specific, so just always remember that. When you're assessing perfusion, just remember capillary refill for kids is our best indicator of perfusion. Blood pressure is a very late sign, so if you check their capillary refill and it is greater than 2 seconds, these kids are not perfusing well. And then just always make sure that you check out all the pulses, so radial or brachial, and then femoral as well. So respiratory effort is always going to be hugely important for our cardiac assessment. Just remember, if they have increased blood flow pumping to the lungs, they're going to have increased work of breathing and shortness of breath and even difficulty with breathing on exertion. So make sure you're taking a look at those. And clubbing can also go along with heart defects that have been symptomatic for quite a while. You already know how important it is to assess for edema in our heart patients. So the only thing I want to point out here is that in babies or even in non-mobile patients, edema may present as periorbital, so around the eyes or in the face, or even in the sacral area, because these patients, they're not up walking, so that fluid is going to disperse in a different way than it would with a patient who's up moving around. Okay, and this last part of the assessment is super important, and it's probably one of the main things that is different for kids. Cardiac problems in babies is often going to present as a feeding problem. Remember, feeding takes so much effort for kids, and for babies, it requires a ton of energy. And it's actually kind of like an exercise stress test for them. So anytime a baby is having a difficult time feeding, we always have to consider that the cause could actually be a heart defect that hasn't gone diagnosed yet. And so things that we might see is that they're not feeding well, they're losing weight, and they're not meeting growth milestones, or even that they're sweating while they're feeding. Signs of heart failure and being familiar with them is really important for our cardiac assessment when we're thinking about heart defects. And the reason for this is because the heart is going to be working extra hard when there's a defect, and because of this, heart failure can develop. And this chart is just a refresher of the signs and symptoms that you've already learned about in your med-surg course, but I've just highlighted in red a couple of things that are specific to children. So I already mentioned that sweating while eating, those signs of difficulty with breathing, so retractions and nasal flaring and grunting, failure to thrive, and then that change in the assessment of edema. Now, as we go through all of the different defects in the other lessons, definitely keep these symptoms in mind, because we are, like I said, going to be classifying all of these defects according to their effect on blood flow. So you should really be able to work through and think through it logically to come up with what symptoms you should be looking for with each of these defects. Therapeutic management for our congenital heart defects is going to be a combination of a lot of different things. So these kids might need surgery, they may need a cardiac catheterization to be done, and then we also give medications, a lot of the same medications that you would see given to adults with heart failure. And a lot of your nursing care around those are going to be the same as well. But one difference that I just really want to quickly highlight is that with digoxin, it's really important that the medication order gives a specific heart rate parameter. Remember, 60 is not our parameter for bradycardia with children. It's going to be different for each age. And so we need that order from the provider to be very clear about when we need to hold this medication. Your nursing care for kids with heart defects are going to be focused on the 4 things you see here. So what we want to be doing is decrease cardiac demands. We want to reduce respiratory distress. We want to support adequate nutrition, and then always be monitoring those fluid and electrolytes. Remember, like I said, a major difference between babies and adults with heart failure is feeding. So we really need to make sure they're conserving their energy so that they can feed, and we want to minimize any kind of stress and crying. So optimal feeding routine is going to be feeding them every 3 hours, and they need to not feed for any more than 30 minutes at a time. And the reason for this is if they take longer than 30 minutes, they're using way too much energy for that feed, and they're going to keep being behind on the calories that they need. They're also going to need a high calorie formula. Now, a lot of the rest of the stuff that you see here about decreasing cardiac demands and respiratory distress and monitoring fluid and electrolytes, it's going to be similar to what you already know for adults. So if you need a refresher on heart failure and the things you'd be doing for that, check out that med-surg lesson that I mentioned that covers all of this. If you are providing care to a peds patient who has a congenital heart defect, your priority nursing concepts are going to be perfusion, oxygenation, and nutrition. All right, you guys, like I said, this lesson is setting the stage for you to go on and learn about the specific cardiac defects that we see in kids. So let's just go over the key points for this one. So remember, heart defects are classified according to how they affect blood flow in the heart. So you can have increased or decreased pulmonary flow, you can have blood flow that's obstructed, or you can have blood that's getting mixed in the heart. And then your risk factors for a kid developing these in utero are having family history, maternal alcohol use and drug use, and then exposure to rubella, the infection rubella, while the mom is pregnant. Remember, your assessment is going to be focused on looking for signs of decreased cardiac function, pulmonary congestion, systemic congestion, and don't forget about that feeding difficulty as being a very important part of our pediatric congenital heart defect assessment. Treatment is going to be a combination of surgery, cardiac catheterization, and then those common heart failure medications that we talked about. And then your nursing care is all about focused on promoting rest and creating a feeding schedule that's going to help that baby thrive, and then watching out for signs of respiratory distress and fluid overload as well. That is it for our just sort of preview lesson on congenital heart defects. Make sure you check out all of the awesome resources that we have attached to this lesson. We've got some great charts and things that are really going to help you process it, and then also use this information as you go ahead and listen to the lessons on the specific heart defects. Now, go out and be your best self today, and happy nursing.